Hi, everyone. Welcome. We are going to be talking about strategies to help our patients with endometriosis today. I'm so thankful you were all able to jump on live. We are recording this, so if you want to review it later, if you have colleagues that couldn't attend because they were seeing patients, it will be recorded and we'll distribute it probably in about a week or so. But I'm super thankful that you're here and I want to be respectful of everyone's time. There might be a couple more people bouncing in as we go, but I'm going to get us started promptly on the hour here. So I'm going to go ahead and share screen here. Okay, we're going to take it from the beginning. So today we are going to be talking about endometriosis. We're going to be doing these special topics here at Intimate Rose roughly once a month. We doubled down this month and we're offering another one tomorrow at the same time on hormone replacement therapy and what we should be looking for to screen our patients and to refer them and what is available to them. And we will be hosting Andrea Martin, who is a certified menopause provider. So I hope that you are able to jump back on tomorrow. That one will also be recorded as well and available at a later time. So we're going to cruise through this, and then at the end, there will be plenty of time for questions. So please don't hesitate to ask those as we come to the end. So our learning objectives for today are that you'll comprehend the pathology of endometriosis and that you'll understand 2 home management strategies for people that have endo. So beginning with what endometriosis actually is, it is the presence of endometrium-like cells that are found outside of the uterus. So these are not the exact cells of the endometrium liner within the uterus. These are just very, very similar, but they are obnoxious. They are associated with an inflammatory response, and they are often stimulated by hormone cycles and the menstrual cycle. So you see here on this diagram, this presence of these cells on and around the uterus that are endometriosis. As we're going to see as we go through this talk, these endometriosis cells can be located far, far away from the reproductive organs. And that's why a lot of providers are classifying this not as a gynecological issue, but more of a pathological systemic issue, because we're going to see endometriosis can be found on the diaphragm, it can be found on the lung, on the intestines. So as I mentioned, prolific and obnoxious. It increases the likelihood of autoimmune dysfunction. So a lot of patients living with endo also have the presence of celiac, interstitial cystitis, other bowel issues, and we'll talk more about that as we go. And the presence of these endometriomas and adhesions are painful. So these patients are living in pretty chronic and exquisite pain. They can also stick to the surrounding organs and can distort the way the organs are seated in the pelvis and in the abdomen and in the trunk. And it affects roughly 176 million women worldwide. The prevalence is currently estimated to be 1 in 10. So pelvic pain symptoms associated with endometriosis include, but are not limited to, painful periods, pain with penetration, whether it's tampon, speculum, or penetrative intercourse, and then also hip, low back, and abdominal pain, to name a few. So looking at the bowel symptoms in endometriosis, it's associated with bloating, abdominal cramping and pain, constipation, diarrhea, painful bowel movements, nausea, and vomiting. And interestingly, for most people, it's the first presenting symptom. So these people often have kind of the upset tummy when they're little, and they might demonstrate some food allergies. And then it comes time for the onset of their menstruation and they start demonstrating the menstrual cycle type pain. So for a lot of people, the first identifying marker is the presence of these bowel symptoms. And this is where, too, and especially in a rehabilitative setting, we can do a lot of good to help these people manage their pain and also manage constipation that might be associated with outlet dysfunction of the pelvic floor. One of the things that we're going to look at is that it can also be driven by the presence of these endometriomas on the bowel itself. And that's where the amazing providers, such as endometriosis surgeons and those that are skilled in medical management, come in to work as a team. So thinking more about bowel involvement, these patients also often have symptoms of IBS, as we talked about, the diarrhea or the constipation. They might also have inflammatory bowel disease. So that includes Crohn's and ulcerative colitis. They might present with true genetic celiac or a non-genetic form of celiac. They may also have lactose intolerance or just a gluten intolerance in the absence of the celiac diagnosis. These patients may also present with SIBO and constipation, as we just discussed. So some of the drivers of constipation with endo might be the anatomic distortions of the endometriosis causing narrowing of the bowel itself or creating kinks where it's difficult for the stool to pass. And they may also have adhesions of the bowel to other organs, including the uterus or the ovaries. And they can fluctuate with some inflammatory mediators affecting bowel motility. They may also have pelvic floor involvement. Okay, we have a question. Okay, Molly's asking, when you say young people, how young? I see primarily pediatric pelvic health, and I've never thought about this as part of my differential. Molly, that's a really great question. I would say right around age 7, 8, when they tend to start presenting with more of the pain in the tummy that they are able to vocalize. Sometimes in the younger population, they don't have the words that we might see behaviors. You know, they might get cranky, they might be like colicky, those kinds of things. Endometriosis is present when the person is born. It is already in their body. So as they are growing as a person, this can present and have all of these different associated issues. So I say 7 or 8 because that's usually when they start having the words to describe, like, my tummy's upset, or you start seeing them being a little bit more like having to lay down. Their stomach is bothering them so much. So hopefully that helps for you. But yes, yeah, absolutely. Yeah, it's important to know. Interesting. I have endo, and my mom and my grandmother have endometriosis. And I always had the upset tummy, and that was not part of our clinical paradigm as a family. It was like very expected because mom and grandmother had endo that I had it. So when I had the symptom onset around menstrual cycle, when I had the pain, that was very expected, and we knew how to push through that, but they didn't quite know what to do with me with the upset tummy. And now as a provider, I recognize, well, that was my first presenting symptom, and sure enough, I have genetic celiac. So yeah, it's really heartbreaking. Those kids are pretty uncomfortable, and so being able to provide that nutritional support, get them tested for allergies earlier on, and then watching for the onset of those menstrual type symptoms as they get older. Okay. All right. Pelvic floor involvement. Okay, on this image here, one of the things that I wanted to point out, this is a sagittal view of the pelvis. We see the uterus here, we see the rectum here, and this is the presence of endometriosis on this image. There's this little pouch between the uterus and the rectum called the pouch of Douglas. And it's a common spot for endometriosis to hide. And it can create a lot of issues with bowel movement. So you can see how it's impinging on the rectum here, and it can cause a lot of issues there. So something that a skilled surgeon can remove, and something that pelvic floor rehabilitation specialists can help with in terms of managing the pelvic floor and the abdomen and providing good mobilization in the surrounding tissues. As I mentioned, endometriosis can be found near and far, including in the thorax and up into the diaphragm and onto the lung. So this here is an image of endometriosis on the diaphragm. These little lumps here are endometriomas. So we can appreciate how this person may also present with some chest pain or shoulder pain, where it's referring back into the shoulder. They might have some issues with breathing. More and more, the more skilled providers are that are doing some of these laparoscopic procedures, the more they are finding it. I can remember 10 years ago, the first time I had a patient present where they had found endometriosis on her diaphragm. I remember thinking, wow, this is so incredibly rare. This person must have it really bad. And certainly the symptoms were pretty bad for her, but it's more common than we think. So we want to be thinking really about the whole thorax. This is not a gynecological disease. This is a whole trunk problem. So with this thoracic endometriosis, patients commonly report chest pain. We want to remind ourselves that the diaphragm is innervated by C3, 4, and 5. If you remember in school, in your anatomy, C3, 4, and 5 keeps us alive. It keeps us breathing. So the pain can refer to from the diaphragm into the shoulder blade and the shoulder area. They may also have some pain in the neck, the chest, or even in the ear, because of a shared innervation with the phrenic nerve. And that may be the initial feeling and sensation for them, is that they have like a tightness in their chest or their shoulder and their scapular area, and it gets worse during their cycles. Medical management of thoracic endometriosis is surgical laparoscopic excision. This is the only means of truly curing it and getting it out of there and off of those structures. Medically speaking, birth control has been inconclusive as a means of management. So we're thinking about those oral medications. Most patients are reporting, at least in my clinic, they're not very helpful. And it's in terms of the actual data, it's inconclusive. And by and large, it's because, again, endometriosis is a syndrome of similar cells found outside of the uterus. So these are not the exact same. So they're not going to respond exactly the same way to a medication that's really meant for the uterus and the ovaries itself. Additionally, hysterectomy alone rarely addresses all of these symptoms. Caveat to that, I will say, I have had patients who did get the hysterectomy and they did feel better. My mom is actually one of them. So I do listen, but I also appreciate how that for another subset of patients, because the endometriomas are found near and far outside of the uterus, simply removing the uterus does not address all the symptoms, especially if they have those endometriomas hanging out on the bowel or all the way up through the intestines, onto the diaphragm, onto the lung. So adenomyosis, separate process where it's found in the muscle of the uterus itself, can often be helped and address some of that pain with the hysterectomy. So it's just to say, but a patient can often feel very disappointed if they get the hysterectomy, they go through that surgery and they come out and they're still feeling pain and they're still feeling inflammation and fatigue and all of these different, a variety of symptoms, bowel symptoms. So that's where we want to make sure that we have a complete comprehensive medical team in place and we're all working together, and that they see someone that really treats endometriosis and knows how to look for it on laparoscopic approach. Visualization of adhesions. This is really cool. I'm going to go ahead and play this here. This is a surgical video taken by Dr. Vitali, and you see these stalagmite type structures here. This is all endometriosis, and we can appreciate how thick some of these are, and we can appreciate how those are pulling one structure onto the other, and that can make it really uncomfortable. And this particular person, their appendix is involved. So just giving you an example of how these structures can stick together. All right. Back to the show. For those that have had the laparoscopic uh, procedures to do excision, we want to ensure that they are getting post-surgical PT or OT management. And in that management, so you can see here, there's often 3 to 5 portals where the instrumentation has approached. It's dependent on the type of procedure the surgeon did. Some of them use a Da Vinci robot, in which case the instrumentation had some pretty long arms where those cameras accessed. And so the little tunnels, we want to make sure that we're there to provide some mobilization so those tunnels don't get scarred down and sticky. And so they often approach through the umbilicus, lateral, and then a couple more down low, depending on where they're looking and where they need to go. Some surgeons do not use the Da Vinci method using the robot, and they do it all manually. But even still, with the laparoscopic approach, there's still multiple entry places, and they do form little tunnels. So we just want to make sure that we are there to help the patient recover. We assess their breathing patterns. Oftentimes, post-surgically, the patient will adapt a very shallow, high in the chest respiratory pattern that can persist after surgery because it kind of becomes a habit as they're healing. And so we want to make sure that they do regain and retain good rib cage expansion and that the abdominals are getting some excursion there so that they get good fresh blood flow to the area and that they are getting resumption of good motor control of those abdominals. So we want to assess their breathing, their posture, pain, and then work with them to help improve mobility of those scars. So we can do desensitization training, first starting with a little Q-tip over the scars and just gently brushing on the sides and then over the top as they're healing, and then a makeup brush, and then teaching the patient mobilization. On our part as pelvic physical therapists and occupational therapists, we can do mobilization by way of manual therapy to their back and their hips and the abdomen itself. Visceral mobilization is a really powerful tool for this patient population. It's perhaps one of my favorite skill sets as a clinician. And if you're a rehabilitation practitioner and you haven't yet taken coursework in visceral mobility, it's super fun. And it's a nice way to ensure that we are able to provide additional training to those organs. It's not necessarily that we're getting in there and we're breaking up scar tissue. It's simply a gentle mobilization technique to bring blood flow to the area, make sure that the organs are slidey and glidey. And also it's a reminder to the brain as to where the muscles are. So getting them some proprioceptive input. As we talked about briefly, as we began, the presence of pain in the bladder is not uncommon, and it's become so common to find endometriosis and interstitial cystitis that it's earned the term evil twin syndrome. So this is when the patient presents with both. And for this patient population, they often present with overactivity of the pelvic floor and pelvic pain that may overlie muscle weakness. So it might be that they have muscles that are too tight from guarding because of the pain, but they might not necessarily be strong. We want to lengthen before we strengthen. That's kind of the paradigm where we want to improve mobility of the pelvic floor muscles using manual therapy and the wand. And then they might need to be retaught how to properly activate the pelvic floor muscles. A pelvic floor muscle activation is by definition a Kegel, but as providers, we want to be really careful with this patient population about using that word. It's gotten a lot of bad publicity, unfortunately, in the last couple of years. And this patient population advocates for themselves really well. So if we as providers say, I'm going to teach you Kegels, they've been taught to run. So it may be that in our plan of care, we need to work on mobility and we're addressing pain and we're getting the pelvic floor muscles to have no trigger points or tender points. And then we are teaching them better motor control of it. But let's use the term pelvic floor strengthening or activation instead of Kegels, just thinking about words that work and not words that might be triggering to them. just an observation clinically. In terms of helping them manage their pain, we can do pain therapeutic neuroscience education. We can do joint mobilization techniques, not necessarily alignment, just more thinking about mobilization, especially in the hips and the spine, where often this patient population guards a lot. And so they don't necessarily get great excursion because of these chronic holding patterns. For some, they might respond well to a little proprioceptive input with a compression belt or taping, just to allow the muscles to relax a little bit and provide them with some comfort and stability. And then, of course, neuromuscular re-education, making sure that the pelvic floor muscles and the abdominals know how to fully relax and how to activate. Both principles are important. We could use biofeedback using internal or external EMG if you have that available in your clinic. Usually, primarily, we're working on down training first. So teaching them how to allow the pelvic floor muscles to drop and expand, teaching them how to isolate them, and then also just improving their sensory awareness. Oftentimes, we know people with chronic pain lose touch with where certain body parts are located. And something completely innocuous can become a nociceptive threat to them. So penetration is a primary example. So just working on desensitization, dilators are helpful for that. We'll talk about that more in a moment. Functional activity training, making sure that they have great body mechanics when they are lifting their groceries or getting from the floor up to the stand, when they're getting in and out of their vehicle, and working on good posture and ensuring that they have all the tissue principles in place that will allow them to produce all of those movements. Electric stimulation and TENS modalities might be helpful. Oftentimes, this patient population has already been searching on Amazon, and they have TENS modalities that they can use at home that can be really helpful. If patients already present and they already like that, that's something that can help them to be maintaining their pain management at home. I have no issue with that. I usually wouldn't hook them up in the clinic and spend our time with that, but everyone has different practice patterns. A little bit more depth on manual therapy for people with endometriosis. Thinking again about the pain that they might be experiencing, those adhesions, those stalagmite type adhesions, and tailoring our approach based off of whether they've had surgery or whether they have not, or they're managing it with medications and whatnot. Skin rolling can be really helpful, especially once those scars have healed after surgery. And then, as I touched on, visceral mobilization to address any adhesions, scar mobilization, teaching the patient how to use a Q-tip first on the sides of the scar, and then onto the scar so that the scar itself can become desensitized, and then working up to a little makeup brush, and then finally using their fingertips. And I always recommend, if the scar is lying here in the middle, that we start on either side, just gently working up and down in parallel with the scar, and then working right to left, so perpendicularly to the scar, and then loading the scar itself. So if here's the scar, just placing fingers on it, putting a little pressure down, almost as if you're checking a tomato for ripeness, and starting to glide the scar itself in that loaded position. So up and down and right and left, and then beginning to work in multiple planes, because we want there to be good mobility. We don't want that to continue to pull on its neighbors. And then rib cage mobility, taking the skin rolling and fascial mobility principles in and around the rib cage is really important, so that they're getting good excursion, and reminding ourselves the diaphragm living within that rib cage works like a piston with the pelvic floor. So we can be indirectly helping regain pelvic floor muscle function when we are working with the rib cage itself. And then additionally, for the hip and the thigh, so joint mobilization to the hip and the pelvis. A really common one is to have restriction in the anterior aspect of the hip joint itself. One way we can get at that is to place the patient prone and to mobilize the femoral acetabular joint with the prone, the posterior to anterior glides in prone. So I usually put a patient prone in a figure 4 position, and then hands right at the ischial tuberosity, and then gently glide down. You could also do anterior to posterior glides with them face up in supine. And then super important, myofascial release to the adductors, reminding ourselves that those adductors go all the way up to the pubic symphysis and the ischial spine, and that those attachments, if they're really tight, can be pulling and tugging on the pelvis as well. A lot of people in pain do tend to guard and keep those legs closed. And then also working the IT band and the hamstrings and the quads as well. So working both above and below. We've talked a lot about the abdomen. Don't forget the lower leg as well. And then as needed, joint mobilization to the SI joint and lumbar spine. An external technique, if you have a patient that's really flared up and is just not ready to tolerate internal work, is to reach obturator internus externally. And I do it. So this is an image of me kneeling. Patient is supine on the table. I have her leg draped over my shoulder. You can also do this in side lying, but I like to work with the hip and flex and extend the hip a little bit as I'm working with obturator internus. I also like to rotate it, keeping in mind the obturator internus is the hip rotator. So we can get a little bit of mobilization with movement. And one way that I find that I can control the leg better is to get up on the table with the patient themselves and just have that leg over my shoulder. The hand that is reaching obturator internus is coming in at a 45-degree angle. You're going to locate the bony aspect of the ischial ramus, and then you're just going to gently dive in and around into the soft tissue there. And then once you find it, you're just going to maintain gentle pressure, and then you can flex the hip and extend it a little bit, just gently rocking back and forth 10 to 12 times, and then rotate the hip in and out a bit. So it's almost like a strain counter strain with movement. And then for internal manual therapy, we're using a gentle approach. We can do strain counter strain to the tender and trigger points. We want to be mindful of the fact that these aren't just musculoskeletal restrictions we're dealing with. This person might have actual endometriomas in and around the muscles and in the fascia that's attaching, and in the surrounding organs as well. So we're taking a really nice gentle approach, tomato touch. So again, as much pressure as we would use to check a tomato for ripeness, not squishing the tomato. And reminding ourselves that too, when we are working with tender points, we're also working with the patient's brain. We're providing some proprioceptive input to the location of that and helping the brain learn where those muscles are. So it's more than just the muscle itself. Okay, some exercises for people with endo. So our intention with our home exercise program wants to be to help improve coordination of the pelvic floor and adjacent core muscles. Want to help provide the patient with better stability and mobility of the pelvis and the trunk. Want to stimulate their bones, tendons, muscles, nerves, and their brain. We want to provide new networking, so new neuromuscular patterns for a better muscled repertoire. Because again, they might have a very embedded pattern of guarding, and then also to help enhance their psychological well-being. So diaphragmatic breathing, pretty common cornerstone to begin with for this patient population. This can be a really great place to start, whether they are wanting to get into high impact activity or whether they are preparing to use a wand or a dilator, checking in with the breathing to help calm their system down and get them in the right mindset for whatever exercises are about to come. You can have them practice different breathing patterns. So hand on belly, hand on chest. They can start by that tactile input into the belly, breathing up towards the ceiling into that top hand there for 10 to 12 reps, more getting their system to be calm and also getting expansion into the abdomen. And then you could also have them work on just keeping them symmetric and equal. You could also have them put two hands on either side of the rib cage or even a little TheraBand wrapped around the rib cage and have them breathe into the sides of the rib cage there. And then I offer patients different relaxation positions. I don't necessarily call them stretches, more just a Control-Alt-Delete type poses. This is one of them. It's child's pose, but with modifications. So this first modification is pillow in the fold of the back of the knee. So we're in the child's pose position here. This allows for nice rounding in through the lumbar spine. It might be helpful for patients that have knee pain and they don't quite want to be in this crunched up, very bended position. If patients have shoulder pain, they can just bring the arms down alongside the knees there. So there's this modification, and then there's modification with the pillow in the front fold of the hip. This tends to allow for a little bit more opening around the vaginal opening and anterior pelvic floor, still getting a lot of opening around the back as well. This also is helpful for patients that maybe doesn't like the feeling of their chest being crunched down into the floor, or if they have hip pain and they don't want an extreme flexion of their hip. This is a nice modification for them. Deep squat. Ideally, heels would be flat. My ankles are super tight and they don't like to go very flat. But this is a nice one that they can do for those that work outside of the home or they're very busy, because this is one that could easily be done at a desk or in a break room. The deep squat is getting some relaxation and opening of the pelvic floor, and then they can do some gentle neural flossing by dipping the chin down and then lifting it back up. So just getting a little lift and extension there. And I have them hold these for 30 seconds to 2 minutes. Other mind-body exercises are the pretty common ones that people might enjoy: Pilates, yoga, specific for endometriosis, or mindful walks. Pilates is one where it's interesting because there is a lot of activation of the abdominals and the pelvic floor. So what I always caution people towards with Pilates, and this being me who loves Pilates and I am certified in Pilates, is to make sure that they are doing it in a classroom setting where the instructor is actively walking around and helping people make modifications. Because what we don't want is for them to go in and do a lot of gripping in through the abdominals and putting a lot of pressure onto the organs and not getting a good respiratory rate. So we want them breathing. We want them to have good coordination between the pelvic floor and the core. But there are different types of Pilates. There's some very gentle forms, and especially on the reformer, that allows them to load their joints and get some nice mobilization. So it's not on the whole necessarily a bad thing. It's not always necessarily the best thing for them too. So just talking with them about what kind of Pilates they're interested in. And a lot of us as providers offer it in clinic. So even better that we can be there helping to ensure that they are doing what's best for their body. And then mindful walks is possibly one of my most favorite things, because literally anyone can do it anywhere, and it can be done even on a 15-minute break. What I instruct patients to do, this is to help with general calming of the system, helping to manage stress and inflammatory processes, is to go out on a walk, no earbuds, just looking for different interesting and beautiful things. So it might be the contrast between a blue sky and a green tree, just like looking at that and appreciating that, or looking for different wildflowers, or how many insects can you see on your walk. Just something that's getting them out of a stress response, out of the pain mindset, and just being more mindful of their surroundings, that can act as a little bit of a reset. And again, even as little as 5 to 10 minutes on a break, 45 minutes if they can get it, that would be great. And then cardiovascular and aerobic exercise. We want to be thinking first and foremost what brings the patient joy. Things like hiking, biking, swimming, and running, we want to be advising for moderate. So intensity is really key with all of these. So when we think about biking, we think of a lot of compression on the pelvic floor and the perineal nerve. So we would maybe, if they were in our clinic seeking care for pelvic pain, talk to them about, can they decrease that and insert something else in its place while we're going through this healing period? It's not that they can't ever bike again, but while we are working through a current pain cycle, and then also ensuring that they see someone who can properly fit their bike for them. I don't know how to do that. I refer out readily for that. There are great, even our orthopedic colleagues can do a great bike fitting for them, or some bike shops can do it really well, just making sure that they are using good posture, but also that they might need to take a break if they're in a pain flare-up. And then with regards to higher intensity, so whether it's running or whether it's a HIIT class or lifting and things, those are all things that bring them joy, and they are not necessarily bad things. But if they are in a pain flare-up, we might want to be working with them on reducing the intensity for 6 to 8 weeks, while we as providers are working on the musculoskeletal principles and helping them manage their stress. Because those high intensity forms of exercise are also associated with their own little kick up of inflammatory response that's very normal to physical exercise, but that might not be helpful while we're going through a rehabilitative plan of care. So we could say, I know you love running. Instead of running 6 miles 3 times a week and a long run on weekends for the next 6 to 8 weeks, can we commit to doing 3 miles and keeping them as easy runs? So using our rate of perceived exertion scales and keeping it lower, like 13 instead of 18, just while we're going through this process, and assuring them that we understand that their goal is to be able to run or participate in those HIIT courses as much as they desire, and that we're going to get them there. But during this time, we want to bring the intensity level down a little bit while we're working through the pain. Because there's positive response to exercise with those endorphins as well, and we don't want to take that away. So mobilization with movement exercises, we talked about the rib cage, and part of that is low mid back. So here's a little exercise that patients can do using peanut ball, or if they don't, they can take 2 tennis balls together. They put it in the mid back and lay down, and they can steamroll and mobilize the back. And then they can also do reciprocating arm movements to mobilize around the shoulder blades. So that's just one idea for helping to improve mid-back mobility in and around the shoulder region, and where the ribs attach, especially if they've had surgery. And then rebuilding core control. There's some ideas here. We all have our favorite exercises that we like to use with our patients, but these are just some ideas of phases of exercise to help rebuild coordination of the pelvic floor and abdominals. So here, just supine, so this could be initiated within days after surgery, of having them squeeze the ball and exhale. Inhale, release, exhale, squeeze, and then bringing one leg up into 90 degrees, and then opposite arm, opposite leg, just a little isometric push. Isometrics have been shown to help reduce pain in joints. This helps to get some oblique activation here to wake those muscles up, especially considering the surgery that has its own little inflammatory response as they are healing. So opposite arm, opposite leg, isometrics, 3 to 5 second hold, and release. Doing it on each side. They could also use a pillow. It doesn't have to be the little squishy ball. And then getting the glutes firing with a little bridge. So adductors squeezing and getting the glutes going. So these can be initiated post-operatively. We're in a phase 1 And then here are some ideas for progression in phase 2. So a little bit more advanced, starting the legs in tabletop and doing just a small activation, hand pressing down to get the lats firing a little bit as well. And then squeezing the ball to get the rotators firing. So we're squeezing in the legs and then drawing in knees abducted to get the inner thighs going as well. And then core activation with having the chin tucked. And then in sideline position, knee stacked, which is hard to maintain, and then getting the adductors firing underneath. So working both sides with stability. And then just getting some chest compression and abduction. So getting the outer part of the hip firing as well. Okay. And then for further progression, getting them moving a little bit more. So I did this post-operatively on myself. You can see my incision marks in my abdomen. I don't often film in my sports bra. I wanted to show how the abdominals are unequal. It was a really humbling experience for me. I want to bring this back and freeze it here a little bit. One of the things that I observed on myself, you can see my little scar incisions here in my abdomen. I had a really hard time getting one whole side of my abdomen to fire. And so what I did is I worked a lot unilaterally, and I think a lot of our patients experience this. So again, working them in a stable environment, supine, side lying, you could go quadruped, but also paying attention to what they look like upright against gravity, because it is a totally different feeling. And we consider there's alterations to the pelvic floor as well. The stabilization of the pelvis and how the abdominals, the diaphragm, and the pelvic floor are working together can be very different for them. So using unilateral exercises like something as easy as a little row to help get each side of the core stabilizing during an upper extremity task can be really helpful. Okay. Home management for people with endometriosis. So this resource, Living with Endometriosis Workbook and Daily Journal, I love this. It's available on Amazon. It's written by this woman, Samantha Bowick. She has a degree in public health, not pelvic health. But she also has endometriosis, and she's a really wonderful advocate. And she wrote a book, but she also created this journal, and it helps the patient to track different aspects of their nutrition and their physical activity along with their symptoms, so that when they go into their provider, whether it's a pelvic health physical therapist or occupational therapist or a doctor or a nutritionist, they're able to show them more data. So this helps track flares in association with what they ate and drank that day, what their physical activity was like, how their stress was, what stage they were in their menstrual cycle, and then other health factors as well. So this is a lovely little tracking resource available here. And then, of course, pelvic wands. We have 5 pelvic wands here at Intimate Rose. We've got the 4 that are all the same size and shape. Either end can be used rectally or vaginally to address tender points in the pelvic floor. I did make the temperature therapy wand endometriosis yellow in homage to endometriosis. Temperature therapy is just one modality that can be helpful for people with chronic and inflammatory associated disease processes. The temperature therapy wand is usually good for patients that do identify as already using thermal modalities to help manage their pain. So they might come in and say, well, I've been using ice packs, or I've been freezing a medical glove and sticking that in my vagina because everything feels like it's on fire, and that seems to help. Or they might be saying, I use a lot of heat packs to help, and that's really soothing to me. So the temperature therapy can be placed in the freezer and will retain cold, or run under very hot water and will retain warm to help provide that modality. Others Wands can be used as well for people with endometriosis. We have a vibrating wand with 10 frequencies of vibration. Some are very soothing, some are a little bit more strong, but vibration helps improve blood flow to the area and is really soothing for chronically tight pelvic floor muscles. It is my personal favorite. And then purple is original. It is just as you see it. And then new to the lineup is the orange wand, which is extra long and bendable. And it allows for additional extra reach. So for patients that maybe have a little extra soft tissue or they have joint limitations that are making it harder for them to reach inside, they can use the orange wand as well. But they can be used internally to address pelvic floor tender points or internally for internal tender points or externally on the adductors or in the abdomen as well, just as you would use the Theracane into the shoulder. So just another point of empowering the patient to help manage their pain at home. Lubricant options for this patient population, if they are using our medical grade silicone tools, they're going to want to use a water-based lubricant. But for intercourse, they can work with their provider to get one that's compounded with lidocaine. This can be a means of just simply taking the edge off for them, just allowing them to have a little bit of a dampened a decrease on their pain so that we can do some manual therapy as rehab providers, or maybe they can be intimate with their partner. We're still working on addressing the drivers of pain. We're not simply suggesting that they throw some lidocaine on it and numb and forget about it, but it's a great tool to help, as I mentioned, just put a dimmer on it so that they can participate in the things that they want and need to on their journey to addressing the root drivers. And then there's lots of different CBD lubricant and suppository options. And a lot of people with endo are enjoying those as a means of, again, just putting a dimmer switch on the pain a little bit so that they can participate in the things they want to. And then dilators yes, there's a question. Molly's asking, what are my thoughts or experiences with pelvic floor muscle injections to reduce increased tension and pain? That is such a great question. And I think it is entirely dependent on the provider doing the injection. There are some really phenomenal physiatrists out there who specialize in pelvic pain, who I know are doing a very good job of isolating and locating tender points that can get in there and shut down a tender point so that the patient is able to participate more extensively in pelvic health physical therapy. So what that looks like is perhaps they get the tender point injection and then they come in and I'm able to get in there more often or more frequently to do internal work or to teach them how to use the wand. So then we're able to address the driver. I've also seen patients get rounds and rounds with certain providers that the patient's getting literally no benefit from whatsoever. So I would say it's highly specific to the person injecting and the person in front of you, because for some, the fear of a needle and the experience of having a needle in and around their genitals and into their pelvic floor is going to be traumatic to the point where whatever good it might do, it's not going to do it for that person. So unique to the patient in front of you and unique to the person doing the injecting. I hope that helps. Okay. Painful penetration. Intimate rose dilators are a helpful means of helping patients to tolerate tampons, speculums, and penetrative intercourse. Ours are the only silicone dilators approved by the FDA. They can be used in gentle progression. So we're starting with whatever the patient can tolerate and then working them up to their goal. So if their goal is speculum, then their end goal is going to be roughly size 4 or size 5 of our dilators, because they may not be interested in penetrative intercourse. They might be having different types of intercourse. For those that are interested in penetrative intercourse, they would go roughly to the size of their partner if they have one currently. And if they don't, then right around size 6 or 7 is a good place to get them to so that they can feel confident in going out and dating and searching for a partner. The clock method is a means of progressing from one dilator to the next. What that looks like is once the patient is able to fully insert the dilator, and for some, they may not be able to get it fully inserted on any given day. If they're having a rough day, they may have been able to insert it yesterday and today they got in a fight with their partner or they had a rough day at work and the body's not relaxing like they want it to. We're always advising them never to force the dilator and that some days those happen and it's okay. Those days don't last. But once they are able to fully insert the dilator, imagining a clock and the vaginal opening for the urethra is 12 and the perineal body is 6, they're going to gently glide down, hold for 30 seconds to a minute, release, go to 7, hold, release, go to 8, all the way around. 12 o'clock is a interesting high traffic environment. We have the pubic symphysis arch here and the urethra, and then the vaginal opening. We also have the clitoral body here living right on top of that. So we want to make sure that that area is getting a little bit of input because 70% of women require clitoral stimulation to achieve orgasm, but we want to make sure that they're not shoving the dilator up and overly compressing the urethra into the pubic bone here. So we're just advising them to be a little more gentle at that 12 o'clock location. And then additionally, they can do body position changes, especially if the goal is intercourse. So having them start in supine hook lying position is a nice, comfortable position for most people. They can put 1 to 2 pillows behind their head and neck and 2 pillows on either side of their knees to allow them to gently open. They can lay on the floor and prop their calves up on a couch or an ottoman, and that's a nice position as well. So more like a 90-90 position. They can do it in all fours position. They can do it in a deep squat. So just encouraging them to change body positions as they are working towards penetrative intercourse. Additional resources on endometriosis for both patients and providers alike. The book Beating Endo is by Dr. Orbeck. She's an endometriosis surgeon. She operates out of LA and New York. She's bi-coastal. And Amy Stein, who is a pelvic PT in New York. So in the Beating Endo book, they cover nutrition and activity and physical therapy and surgical management. And then, as I mentioned previously, the book Living with Endometriosis, and then the workbook and journal that helps patients track their symptoms. And then the Center for Endometriosis Care is an actual facility by Dr. Sinervo, and they have a ton of online resources in clinical care. They have a fabulous nursing team who is very compassionate, and they put out a lot of really great work. And then the Endometriosis Summit, it's an actual event, but it's also an Instagram account and an online resource. It is run by Dr. Sally Sorrell. She's a pelvic PT, and Andrea Vidali. He's an excision specialist, and they are phenomenal. And they run a lot of really great education. And the online meeting or the annual meeting is also held online as well for people who can't attend in person. So those are some resources. What questions do you all have? Any questions?
I just want to say thank you, Amanda. You did answer my questions that I put in the chat, so I really appreciate that. One additional question I have about pediatric pelvic health and endometriosis. So much of what I see in pediatric pelvic health is related to bowel dysfunction and constipation problems. Again, talking about differential diagnosis, at what point should I start saying, like, hey, maybe this might be an endometriosis factor and would refer, you know, to a GI specialist or a gynecologist or something like that?
if they are presenting with the GI type symptoms and they are menstruating and you are also hearing menstrual pain symptoms, more than just like, oh, I had some cramps and that was a rough day, like missing school or like really and truly profound pain, I would make the recommendation early and as often as possible. And then the referral should absolutely be to a person who has extensive training in endometriosis. Unfortunately, what I've observed both professionally and personally is there's a lot of OB-GYNs who do general practice. They're delivering babies. They're doing like the wide gamut. They've got all the people and they say they treat endo and they cannot identify endometriosis on a slide in front of them. It's a very particular disease process, and it's not just a gynecological disease process. And that's why there's people that dedicate their entire professional careers to doing it. So it's important to have those resources available. So for example, I send people 5 to 8 hours away from where I live because that's the closest access I and my patients have to those kinds of people. Does that help?
Yes, thank you so much. I appreciate it.
Yeah, you're welcome. I think there was another question in the chat here. Okay, yes, this is recorded and it will be sent. Hi, Catherine. Okay, do endo patients require lifetime PT maintenance or they can progress to self-management? I would say a little of both. Self-maintenance for endometriosis is an ongoing daily thing, a little bit like brushing your teeth. So they just have to be mindful of their nutrition. They have to be mindful of, using the wand as needed during flare-ups. But I would say that there's just going to be phases of life where they need to come back in for treatment, but they don't need to be coming into appointments weekly for the rest of their lives. But it might be that they come in during a bad pain flare-up. We empower them with exercise. We get the manual therapy going. We empower them with exercise and nutrition and a wand or dilators. And they reach their goals and they go out and they live their life. And a couple years later, life changes, hormones change. Changing hormones can absolutely drive a flare-up in endo. So for example, reaching a perimenopause stage where the estrogen levels start going kittywampus, that person might start to experience general pelvic health changes, urinary incontinence, increase in pain, those kinds of things. And so you might see them back. So you're always in their canoe, but you might not always be the one paddling in any given phase of life, is what I would say about that. Okay, what does the evidence say about success rates for endo surgery and excision? Currently, I think what the data is suggesting is that the patients that undergo excision with a well-trained, so MIGS, minimally invasive gynecological surgery, it's a whole training paradigm for these surgeons, is they experience 80% recovery of pain and function. Fertility is a different ballgame. So it depends on your definition of success. I think most of us can say decrease in pain, 80% reduction in pain just from surgery is pretty good. And then we're there on the rehabilitative side to work with the rest of it and to empower them and to help them get through. So there's also this paradigm of when a surgeon goes in, did they get it all? And did they get everything? So that's where it's variable based on the surgeon as well, because endometriosis can hide in little nooks and crannies. It can present in different colorations. That's another problem with endometriosis, depending on how old it is and how old the person is and their current disease state and the staging of it. There's different stages of endo. It can present red, it can present maroon, it can present white. So that's where the variability in the disease is still challenging. The variability in training of our surgeons is challenging. So all of that affects it. But yes, I think the current data, last I heard, was generally speaking, roughly 80%, with fertility being a different conversation. Okay. Frequently see patients with poor response to endo excision. They wish they had never had surgery. Oh, you suspect that the post-op management is very important to guide them through. Yes, absolutely. It's it's a team, it's a teamwork. And that's why I shared, all of the things that we do post-operatively, to get them firing again. And that's why I showed too that image of my abdominals, like the coordination piece is really important, to retraining those muscles how to fire on time, because otherwise they can have additional pain that's being driven from musculoskeletal type issues. Yes, endospecialist is key. Absolutely. Some resources for that of providers that have been checked by other providers and patients are the Endometriosis Summit, Nancy's Nook, and American End of Endo Project. They have a database. American End of Endo Project is a little bit newer, so the database is still growing, but those are doctors that have been checked by other patients. And Nancy's Nook is run by a extremely world-class nurse who worked alongside one of the best surgeons in the country, and she developed her own list of providers as well. So that's another great resource, Nancy's Nook. And she has a Facebook group as well. Oh, thank you. Thank you for coming. It's my pleasure. Thank you. Are there any other questions before we log off? Yes, another presentation in the future. Tomorrow at this same time, tomorrow at 9 o'clock, we will be here. I will be here with Andrea Martin, menopause specialist. We're going to be talking about hormone replacement therapy and how to screen our patients for that, when to refer, and what treatments are available for our patients in perimenopause. So that's happening tomorrow. It will be recorded. We'll send it to you. And then I'm looking at dates to continue these probably once a month in the spring and in the fall of different topics. So, oh, you've enjoyed my teaching style. Thank you. I appreciate that so much. Yes, so that one tomorrow will be recorded and we'll send that one out. But if you haven't registered yet, go ahead and register, even if you can't make it. And that way you'll get the recording sent to you. Oh, thank you, Kayla. Thank you. All right. Well, I appreciate you all joining me live here. I hope you have a great rest of your day. If you run out of brochures, don't hesitate to email support@intimaterose.com. We'll send you more brochures with your code. Your patients love using their discount code. So thank you to those who share that code with them. You all have a code. If you don't remember it, email support@intimaterose.com and we'll get it for you. And then I'm always here as a resource for all the clinical things as well. Thank you. All right. Have a great rest of your day, everyone.